So thank you, Thomas. My topic today is to give an overview of the respective contribution of both adjuvant and neoadjuvant in the evolving management of pancreatic cancer. So we now know the clinical landscape of pancreatic cancer, which for subdivision, and most of the patients, of course, we have metastatic disease, which is assimilated to systemic disease. However, the border between localized, locally advanced, and borderline resectable disease is a little bit confusing if we trust to more and more data supporting that probably almost the patient with pancreatic cancer has systemic and disseminated disease. So what is important at the initial decision making, which of course should be multidisciplinary and as perfectly described by the previous speaker, should rely on a multi-slide CT scan, is to decide if we go to surgery or not based on the resectability criteria. For the rest, if L0 resection is likely to be done, I think that most of you will go for surgery and then give adjuvant therapy. But more and more, the question of neoadjuvant therapy, maybe perioperative therapy, will go in the future. For borderline resectable disease, which L0 resection is unlikely or at risk, we can do what we call not neoadjuvant, but induction therapy, and then try to resect the tumor. Or some surgeon, maybe experienced surgeon, will claim that they can resect the tumor, and they go for upfront what we can call risky surgery. And the third situation, as previously described, it's that the tumor will probably never be resectable, and then we go for induction, chemo, then chemoradiation maybe, to try to go for improbable surgery. Facing this broad spectrum of different conditions, what has been described based on CT scan, and if we rely on the different guidelines provided by the national and international society, one thing are clear. It's clear that adjuvant therapy is evidence-based with high level of evidence and strong recommendation. While for neoadjuvant therapy, clearly the evidence level is quite low, but the recommendation is increasing, coming from strong to moderate if we consider the borderline setting. Sorry. Let us see the evidence trial in the adjuvant setting. I will not go into detail. This is historical data, but important, of course, coming from 30 years old. And you can see that chemoradiation was firstly described as a benefit in US, and it's still kind of standard, but was not confirmed in Europe by the EORTC trial and by the SPAC4 and SPAC1 trial, who claimed that only adjuvant 5-FU was of benefit for the patient. Gemcitabine was shown as benefit derived from the CONCO-01 trial. This is clear with the doubling number of 5 survival. The SPAC4 shown that equivalent data are for 5-FU and gemcitabine used in the adjuvant setting. This is the same with the EORTC trial with 5-FU and gem plus radiation therapy, and recently published from Japan, the amazing and impressive data coming from the JASPAC trial, and stating that S1, which is an oral furosemide, do very better than gemcitabine, and you can see here that the results are quite impressive with a benefit of more than 21 months in terms of median overall survival, with an impressive hazard ratio and a P significant for non-inferiority and superiority. So this is clearly a new standard in Japan. Coming now to the SPAC4 trial, the aim of the SPAC4 was to assess the combination of gem plus capecitabine, again the standard, which is gemcitabine, and the goal of this very well-known study, which enrolled more than 700 patients, is to detect an hazard ratio of 0.74 for overall survival. This was planned as a pragmatic trial, including R0 and R1 resection, and all patients was included irrespective of post-operative CA19-9 concentration. And this is maybe a pragmatic trial, but this is probably a matter of debate and of bias. SPAC4 met its endpoint, and you can see that survival is better for the combination therapy, but the hazard ratio is not as expected. It's 0.82, and you can see that if the median survival are better for the combination arm, there are overlapping confidential interval in this analysis, and you can also note that the curve only separates after 2 years of follow-up. Another point in this analysis with the different pre-specified subgroup analysis is that only R0 patient benefit from the combination, but not R1 resected patient. So the question now is, should we change of practice and or guidelines according to the data? I think that we have to acknowledge that SPAC4, it's a well-done randomized and very big study, and primary endpoint were clearly met. But I think that we have to raise some methodological issue as regard to the pre-planned hazard ratio and 2-year analysis. There is overlapping confidence interval for median overall survival, short follow-up for the last enrolled patient. There is no difference in DFS. There is a very low rate of post-recurrent treatment. Around less than 40 patients benefit from new chemotherapy after they recur. So this is not usual. There was imbalance for venous resection, and which was pragmatically proposed, is in fact a problem because some patients had increased CA19-9 after surgery. So I think that we can consider that this is probably interim analysis, and we have to wait for mature data, and probably then we can see that maybe GemCap is a new standard. Nowadays, I think that we have to state that gemcitabine is a new option and also a little bit more toxic. Here I listed the survival impact of the long-term data in the adjuvant trial. You can see that gemcitabine doubled the survival rate at 5 and at 10 years. This is clear. There is no benefit of adding erlotinib in the Concours 005 trial, and just recently presented the ASCO coming for the ORTEOG trial. GEM and 5FU are equivalent. GemCape probably is better, but these data rely on a very low number of patients, and the winner probably JASPAC trial, clearly the standard in Japan, but we don't know what is the effect of S1 in the Western world. So here are listed the key ongoing phase 3 adjuvant trial, very important to address the benefit for combined chemotherapy, which is used in metastatic settings. So briefly, we have the Italian FOLFOXIRI, we have the French modified FOLFIRINOX, and we have the Gem-Abraxane combination, which are all tested and evaluated in the adjuvant setting. But we have to note three different points. I think that DFS is now an acceptable endpoint and will be considered in the different adjuvant trials. I think that we have relied on a strict selection of patients, and at-risk patient with a high level of post-op CA19-9 should be excluded, not as it was done in the SPAC4. And I think also that we have to rely on strict and planned follow-up, which is mandatory to avoid bias and problems in follow-up. So this is clearly the conclusion of these studies, and surgery plus adjuvant chemotherapy is the standard. But if we look to the long-term results, this is clear that there is survival benefit from adjuvant therapy to surgery at 5 and at 10 years, as reported recently the JAMA. But you can also see that 25% of the patient will die within the first year, 50% will recur, and nearly 40% of the patient did not complete adjuvant chemotherapy. So clearly, we have to move to another way to treat our patient and to select our patient. And this is clearly the aims of pre or perioperative therapy, which will increase resectability, R0 resectability, convert borderline to resectable and disease, and to go to tumor shrinkage, to target occult disease, to avoid treatment delays, and also, last but not least, to provide a unique window to identify patients with rapid progression who can spare for ineffective surgery, and also to study the in vivo effect of therapy on tumor biology and response. So clearly we have to move that, but these are some hurdles to not only to include patients, but to have an appropriate and well-accurate selection of patients. So for this, I think that we have to stick on clinical selection of patients. That means good preparation, technical preparation. That means FNA, nutritional assessment, biliary drainage if obstructive journeys. We have, of course, to rely on the radiological selection as proposed by the radiologist, and probably in the future go and rely on molecular selection based on gene profile and genomic signature, as it was providing in an emergent literature by different authors published recently. I will not go into details and come back to this selection process because of sake of time, and I think that we have to clearly rely on the contact between vascular and tumor, and this is clearly established, as mentioned by our radiologist. But I want to underline that probably this classification between borderline resectable and locally advanced type A, type B, it's probably evolving depending on improving management. And the more we will go to neoadjuvant or preoperative or induction therapy, probably this classification will change based on our effective therapy, which are coming now with FOLFIRINOX, gemabraxane, and new combination. Does neoadjuvant therapy improve survival in pancreatic cancer? In fact, we don't know. We have only meta-analysis available. This is a mix of small study, retrospective, small phase 2, and I will not go into details. The evidence is quite low. You can see that the type of chemotherapy, of radiochemotherapy regimen is hugely heterogeneous. The trial include in meta-analysis, it's retrospective, small phase 2. The number of institutions, the type of institution is also highly heterogeneous, the number of patients, and also the resectability criteria. The definition of the resectability is also highly variable. So what we can do from this kind of analysis is that probably resection could be prognosis, and that the patient who underwent resection probably do better that those don't want. Recently, it was published a strength analysis, what we call a propensity score match analysis, and it compares two population, one with upfront resection and one with neoadjuvant therapy. And we can see in these two figures that patients who receive neoadjuvant therapy are a good survival and better than the upfront resection. And these figures remain the same for the patient who receive adjuvant chemotherapy. But I think that even if it's a good signal, this study have a lot of bias. It's retrospective. Patient selection is not clear. The type of neoadjuvant therapy is not clear. And last but not least, the patient who got neoadjuvant therapy, but without surgery, were not included. So I think that, again, this is low evident and not a robust study. What to do as neoadjuvant therapy and induction therapy? You can see here with a different color that there is a lot of combination possible. Indeed, we don't know what is the good chemotherapy, FOLFIRINOX, Gem-Abraxane, how much we have to give. Should we give chemoradiation upfront, long chain with capecitabine, or the new techniques with short course of stereotactic body radiation therapy, or the complete sequence? Indeed, we don't know, and we have only small data reporting that FOLFIRINOX, that is the key message here from this kind of analysis. This was published in Lancet Oncology, which is a meta-analysis, but based on small series, heterogeneous series, etc. So the level of evidence, it's not high, but the key message is that FOLFIRINOX plus or minus chemoradiation is feasible and is active in terms of response rate, tumor control, and that we can convert non-resectable or borderline resectable tumor to resectable ones. Another important point is the pathological response rate, and I think that again we have emerging data. This is a series of 80 patients receiving FOLFIRINOX plus or minus chemoradiation. Chemoradiation was given in 65% of the patients, and what is observed is interesting because we can reach prevalence of 26% of complete response or major response. So this is a good signal for those who want to give neoadjuvant of induction chemotherapy. Probably chemoradiation is a little bit better than chemo alone if we rely on this limited number of patients. And the message from this kind of publication is that you can see that DFS, PFS, and overall survival is better for patients with measure of complete response. So we are now reaching what we have observed in esophageal cancer, in rectal cancer, and we are going now smoothly to observe that in pancreatic cancer. Is chemoradiation required after induction chemo? For one, which modality? We don't know. I think that we have to rely on the different trials which is ongoing. This trial will compare FOLFIRINOX followed by chemoradiation, or FOLFIRINOX followed by stereotaxic short course radiation therapy. This is a French trial with a good question. After 4th cycle FOLFIRINOX, organization of chemoradiation will be randomized, and you can see that here. After restaging, chemoradiation will be proposed to half of the patients. This is a very good trial to answer to this question. Another important message is what to do after the whole sequence, chemotherapy, chemoradiation. Should we explore patient in case of non-clear response at the CT scan? The answer is do not trust on imaging findings. I think that if you don't see progression or if you see response of stabilization, you have to explore your patient at the surgical level, and you will have good surprise, for instance, complete pathological response. So this is an important message. I will not go into details about the data provided with gem-Abraxane combination, because this is similar figures that FOLFIRINOX. There is emerging study, small study, which show feasibility of the sequence. It shows resectability, which show also pathological response and complete response. So this is a work in progress. We have to rely on a good trial, which is launched here in Germany, comparing neoadjuvant plus adjuvant compared to only adjuvant therapy in resectable pancreatic cancer. And it will be important to see what is the DFS rate after both sequence. Of course, it's tempting to compare the different regimens, nab-paclitaxel plus gem against FOLFIRINOX, because we need this data. Before conclusion, I would insist on an important point. I think that if you embark your patient in neoadjuvant or induction therapy, you have to evaluate response. This is crucial to evaluate as early as possible the responders or the non-responders. And for this, we will, of course, rely, but at the end, on the pathological response, which should be clearly standardized and evaluated by our pathologist. We have to rely on dynamic and functional imaging, PET, MRI, etc., and on circulating marker. CA19-9, it's probably a good marker for those patients who express that. You can see that they can predict resectability, and it could be prognosis for the patient, but the future, it's probably the evaluation in the blood of the circulating DNA, etc. I think that, and I encourage to do that, if we go to neoadjuvant therapy, it's to build a very well-designed trial combining not only therapy, but also translational research, combining biomarker signature, circulating and liquid biopsy, and functional imaging in a well-defined sequence. This is important. So for the conclusion, I think that adjuvant chemotherapy is clearly the standard after S0, A1 resection. Gemcitabine is similar to 5-FU. For cycle, it's important to give 6 months of therapy. S1 is the standard in Japan, but we don't know what happened in Western country. GemCape is a new option, maybe not the standard. For this, evidence is increasing. Adjuvant chemoradiation is not a standard, at least in Europe. Standard chemo used in metastatic is now evaluating in a big trial in the adjuvant setting, and the future is probably to move to translational program and to use circulating and liquid biopsy around this trial for monitoring our patient. For the adjuvant induction therapy, it's not a standard in potentially resectable tumor, but it's emerging in specific case. ASCO statement state that can be used in specific characteristic, suspicion of extrahepatic disease, questionable operability, high CA19-9 level, and vascular contact. Evidence is low, but recommendation is increasingly proposed for borderline tumor. Response evaluation is important. The role of adjunct or adding chemoradiation is not yet answered because it's done half of the series reported. It's a good explorative window, this setting for a new trial, but we have to launch this trial in distinct settings. So clearly define what is resectable, borderline, or locally advanced disease. I thank for your attention.